Okay, let's see what I have more. Maybe gait. These are rotating topics for me, by the way. That's why I need to I need to go through these. And gait is it's also, I don't know how to study it, but I think from the way of the gait, it's makes more interesting. So whether it's wide or narrow or maybe stiff or I don't want to put a lot because it will be nothing, or maybe staggering gait, or maybe what, ipsilateral. Now wide gait, you have three differential. So guys, by the way, wide gait means I'm talking about sensory problem. So usually it's sensory ataxia. So wide gait you can differentiate it either sensory ataxia, and sensory ataxia you have two differential. The first one is just dorsal colon problem, which is basically or peripheral nerve roots, or peripheral nerve or roots, and usually could be, this could be syphilis, right? Or could be maybe vitamin B12 deficiency, but usually it's syphilis. So this is sensory ataxia, dorsal colon, nerve roots. So this is just a neuro syphilis, or maybe vitamin B12, or maybe it's sensory, but the problem was cerebellum. So this is much easier. So it's just cerebellum problem. So when cerebellar problem, we will stop here, cerebellum. Now, which one have Romberg's sign positive? Is it in cerebellum or in the dorsal colon, or I mean this in neurocephala? Right. So which one? Sorry.
Cerebellum.
So cerebellum means what? Means when you ask the patient to close his eyes, right? Patient, and then you ask the patient to stand and put his feet together, and then extend maybe his arms, and then ask the patient to close his eyes, right? So since if it is cerebellum problem, I got confused. If it is cerebellum, are you sure, guys? Anyone fresh with the step one? Oh, you sure? Yeah, I don't know why I get confused. Maybe, yeah, I was thinking also cerebellum, but now when so here, yeah, that's why. Yeah, that's why I'm. Yeah, I remember it's dorsal colon problems. If it is. Yeah, because. No, yeah. Yeah, yeah. I think, yeah. Although she said she's sure, but I think Rombert's goes with dorsal colon. Those people, even if because if they will close their eyes and compensate, that means I think the cerebellum working. I don't know. I don't know. I just blocked, but I prefer to put it under dorsal colon.
The patient will sway anyway whether the eyes are open or closed.
Right. In cerebellum, when the eye open, hey, I forget it. And when I lose a connection, I cannot discuss. But I will just put it here, Romberg sign under dorsal colon, because that's what I think. But I cannot now explain. I just got it blocked. But I will make a question. Maybe you guys, you have to look at it to make sure it is Romberg's positive with dorsal colon or cerebellum. But I prefer to put it there, which basically when he closed his eyes for me. When he opens his eye and has a problem, that means cerebellum. Cerebellum, he has problem, whether he's closed or open. That's what I think, and that's what one of the students now also said. That's what I'm thinking. Anyway, so you have sensory ataxia, which is basically cerebellum, remember, and neurocephalus and these dorsal corner. But you know, when he's talking about cerebellum, guys, you remember these big signs, which are very easy. So you have an intention tremor, right? You have bradykinesia or dysdiadokinesia, whatever kinesia stuff, and you have what else? Nystagmus. So he has to tell you some other stuff about to make it cerebellum for you. All right, so it will not be so hard.
Dr. Riyad, excuse me just for a moment. I just checked about the rhomboid.
Yeah.
First aid, it is a positive rhomboid with a dorsal column problem. And that's the standard patient with the eyes closed and they will sway.
Right. Right.
And the other one is the one, the cerebellum is the one where they will sway with the eyes closed.
Right, exactly. Yeah, that's what I was thinking too by the end, but I don't know, I just get confused. So yeah, so it's Romberg's, as we said, dorsal colon, Romberg's positive, that's mean when the eye closed. And the cerebellum, whatever, he's just sway, right? Because of cerebellum not functioning. Now, what else? One more thing. Yeah, one more thing I can put it here. I don't know why I put ipsilateral there. One more thing we can add in cerebellum. Usually those patients fall toward the lesion, and I think this is a kind of interesting. So the patient falls towards lesion. That's why they call it ipsilateral here. All right, this is also interesting. So you get one sensory, which is wide base gait. So you get sensory, and another things also. Although it's waddling gait more than the wide one, but I don't know. I prefer to put it here just to make a category or to create a category, which is basically muscle dystrophy. And the muscle dystrophy that the patient presents with wide gait or waddling gait basically is gluteal muscle weakness. So here it's waddling gait or gluteal muscle weakness. Alright, so this is the wide. So you get the three: cerebellum, dorsal colon, and the gluteal region. The gluteal muscle, sorry. What else? Narrow, very easy, guys, which is shuffling gait. We just mentioned it. Patient is slow, bradykinesia, rigidity, stopped postures, masked face, 73, this is Parkinson. Yeah, I mean, this is really so easy. Stiffness, history of vascular disease, hypertension, stroke, whatever. So basically you are talking about upper motor neuron signs usually. Upper motor neuron signs, which could be the one that is just after stroke, or could be spinal cord problems. So just upper motor neuron, I think this is the issue, which is cerebellar. Usually I think they divide it whether it's a spinal cord pathology or cerebral cortex pathology. So you have spinal cord, which is usually stiff when he walks. So I think, yeah, we're almost done, by the way. I thought we will have more. Oh no, staggering. Staggering means, I don't know how to explain it, but you can see. Yeah, it could be alcohol, but the prototypical example of staggering, which is basically, he will move one of his legs as a kind of wide when he move it, and the other one is just in neutral position. I don't know exactly how to explain it. Maybe you can just Google it or just see it in YouTube. You'll see, once you will see it, how it looks like, the staggering. But things for staggering for you guys, usually he has movement of the head during walking. So he will also move his head while he walks. Movement of head during walking. This is a kind of specific. And the main differential here is vertebro-basilar problem. So basically we are talking about vertebral artery ischemia or vertebral ataxia. And when I'm talking about vertebral ataxia, if you remember yesterday, that means he will have maybe vertigo, you will have nystagmus, this stuff. Alright guys, so this is another one. So you get vertebral differential, cerebellar, cerebral, spinal cord, Parkinson. Look at how much. 1, 2, 3, 4, 5, 6, 7, 8. All of they really like to put all of these together in a gait. They really like to put more than 5 options in gait, in dementia, in maybe seizure, in vascular. I don't know really why. But I think gait questions is not so hard, guys, because usually what the one that they will like, and it's very easy, the one that they will like, and I think you are also good with these. They like the cerebellum, which is he has to tell you something about the intention, tremor, or anything in the past. So they like cerebellum one. They love the Parkinson, which is very easy, narrow. I don't think the others are high yield, but they put it there, and you will see it. But I don't think these are high yield like these two stuff. And I think even if you are not here, I mean, you know the Parkinson and you know also cerebellum kind of white gait. But the sensory isn't interesting for me. Anyway, so any question? Okay. I just would like to make here a trick for dementia acute treatment, although it's not, sorry, I have to mention it before. Dementia corrected, I mean reversible. So any patient, let's say you have patient 50 or let's say 60, he came with altered, although the altered mental status will be big topics, but because I just now remember it, I don't want to forget it. Altered mental status. And you think this is a kind of acute dementia or maybe delirium, right? So maybe this is delirium topic, I think. Altered mental status, guys, you have to rule out 4 causes because 4 or 5 causes are really treatable. I will give you the treatment and you will tell me the disease. So one is treated by thiamine, which is very easy. So what do you think the disease will be? Right. Another one is treated by glucose. So what do you think the disease or the problem will be? Hey, hypoglycemia. Another one treated by oxygen. So what do you think the problem is? Hypoxia. Another one treated by naloxone. So what do you think the disease will be? Overdose, right? Opioid overdose. And the last one treated by antibiotics. So which is infection. Always don't forget. So thiamine, we are talking about alcohol problems and ataxia and confibulation. So we're talking about Wernicke. Glucose, we are talking about hypoglycemia. Hypoglycemia could be presented as delirium. Hypoglycemia could be presented as anything, by the way, anything. Oxygen, any hypoxia problem, patient is hypoxic, whether it's COPD, exacerbation, asthma, or whatever. Naloxone is important. You will see pinpoint pupil here. So basically we are talking about drug overdose, respiratory depression, and here maybe important is fever. So don't forget these options. If he will give you these options, that means he's talking about these diagnoses. I just now remember it. It's there will be a talk about altered mental status, how to approach it. All right, so let's move further. So we're done with dementia. We're done with gait. How about acute delirium treatment? Yeah, let's make it here. We add it to the. Sorry, let's add it here. Whatever the causes, whether one of them, 2 of them, none of them, but the patient now severe agitation and screaming. He is nursing home resident patient. Let's say he's screaming, and you cannot control him. I mean, how you control these guys? He's severely agitated, And you do restrain, usually we restrain those patients, you do restrain, but still he is really severely agitated. So the drug of choice for severe agitation is haloperidol. Always, always. Halidol is a drug of choice, guys, which is very easy. And halidol, usually you will use low dose halidol. Why? They found this halidol is okay in acute setting. So halidol, by the way, if you will give 1 dose or 2 doses or maybe few doses within few days is fine. So short term, halidol is okay. Long term halidol, that's mean the patient on halidol for years or months, this will increase mortality. Just in case, long and short. So this acute delirium, by the way, treatment, which is halidol, I don't think it's hard. Anyway, what else we have? So good. We're done with these two crazy topics. Now let's go to more. Let's go to some movement, because we're already talking about maybe tremor. Let's see if I'm ready with the movement here or not, because yeah, let's talk about movement, which is basically tremor, at least, which is very high yield question. So I will give you now scenario about one of the tremor, and you will tell me what's the diagnosis of this tremor. So it's worsening by, let's say first it's resting. So the tremor here, you have it, is resting. And I think once I will say resting, you have to know the diagnosis, by the way. So it's resting and unilateral, so just one limb, so unilateral tremor. And it's really fast, so it's 4 to 5 cycles per second. No family history of this tremor. And the patient is old age. The age is not important. And then the tremor decreased, right, or improved with movement. So improve with activity. I think this is easy, guys. Diagnosis.
Parkinson?
Right. And this is the first presentation of Parkinson disease. So here we are talking about Parkinson disease. So Parkinson tremor, you will see the resting unilateral. It's really quick, really fast, 4 to 5 per second. No family history, and improve with activity. So this is the first manifestation of Parkinson disease, is the tremor. By the way, how you treat a tremor in Parkinson disease? Okay, I will talk about that in Parkinson. Give me 1 second. Yeah, exactly. Try Xvinidil, which is atropine antagonist drugs. So now maybe just put everything the opposite to make the other kind of tremor. The other tremor, which is maybe you can put bilateral, or it's not resting. It is tremor increase with activity, right? And this also increase when the patient is insomniac. So increase in insomnia when he cannot sleep. So that means the sleep improve this tremor. Usually this tremor upper limbs more than lower limbs. Usually it is slower than the Parkinson, although it's still they consider it fast, but it's slower than Parkinson, I think. And then family history could be positive. And I think that's it. It's not resting, the opposite of resting. That's mean intentional tremor, when you want to hold something, but it's suppressed by rest, which is the opposite. So it's active. I think it's easy. So what's this tremor, guys? Now this is essential. Give me the drug of choice. Hey, hello, drug of choice. Yeah, propranolol.
Propranolol. I saw this in a patient last week. It was really, really bad.
Oh, really?
And she has it because I've never seen it before.
Hmm.
It was really bad. Trying to get an IV into her arm was terrible. And then when her daughter showed, her daughter has it too.
Oh, really? So it's family.
Into develop the symptoms, but the mom had it really bad. But the daughter, you could tell, she started to shake a little. It was terrible. I was like, what is this?
So if this patient is asleep, Ellie, if this patient is asleep, during sleep, she's still having a tremor?
Actually, no.
Right.
But then the problem was she had insomnia really bad.
Oh, that's why. Uh-huh.
She woke up and she was really confused. She was like, "Oh, I'm ready for dinner." And she was dressed up. And I was like, "No, Miss Porphyria."
Oh my God, yeah.
And then we had to reorient her. But then when she's asleep in bed, she's perfectly okay. If she doesn't sleep, she sleeps for like 20 minutes.
So what do you give her for sleep? Did you give her Halidol?
No, definitely not.
So what do you give?
No.
Yeah.
They gave her a mild dose of restoral.
Oh, which is benzodiazepine. Yeah.
She didn't go to sleep. She was still up.
Yeah, we usually hate benzodiazepine in old people because of the respiratory depression, but Halidol in acute setting, by the way, it's not so bad. Except if cardiac problem. Which cardiac problem? You will see it in the EKG, and then you will not give Halidol.
She has stents.
No.
She had a cabbage before.
Yeah, but this is not contraindication. What is the contraindication? If you will see something, and it's not absolute, by the way, contraindication, but you have to check the EKG. If you will see something in the EKG, you don't use Halidol. What is this something means? Sorry? Oh no. QT prolongation. So those, because Halidol already make the patient QT prolongation. I remember we give a patient because of this agitation 2 or 3 weeks, we give him, Halidol every 2 hours, maybe 5 milligram. PRN. So we make it PRN Halidol. Every 2 hours, 5 milligram or 10. Oh my god, the next day QT interval was just crazy. Maybe it was 600. Really, it was crazy. So Halidol with QT interval, big questions, and so common. A lot of those antipsychotic side medications, they came the patient with, with just high QT interval, and we will admit them, and because we just need to monitor QT interval, by the way. We will just do serial EKG for those patients. Yeah, just in case we'll give you psychiatric. Serial EKG will be the answer for Halidol or for antipsychotic intoxication in general. So you'll do serial EKG until to make sure the QT. I mean, you will stop the drug, sure, and then you'll do serial EKG to make sure the drug is not here anymore. So okay, she said propranolol, and let's say the patient have history of asthma and she's asthmatic or COPD, and so you don't need to give them propranolol because of the contraindication, I guess. So what you will give instead of propranolol? Did you give them alcohol? Is alcohol is a treatment, by the way? Right, Primidone. Yeah, alcohol is. They said alcohol is improved, but it's not modality of the treatment. So those patients usually alcohol improve the symptoms, but it's not modality of the treatment. So modality of treatment, propranolol first choice. Second choice, I remember second choice 1 or 2. Clonazepam is in the second choice, which is a typical antipsychotic, and the second one is Primidone. Now, the Primidone is interesting. It's a kind of, I think it's a kind of anti-convulsive medications. Why? Primidone, when a Primidone metabolized, a Primidone will metabolize into phenobarbital. So that's why it's Primidone has to be metabolized inside the body into phenobarbital. That's why it's used, I think. Now the question is, let's say you give this patient a chronic not a chronic phenobarbital, you give the patient chronic Primidone, and then the patient come with acute I'll make it here with acute abdominal pain, colicky in nature. So you are talking about abdominal pain and colicky, acute, very severe, and maybe patient come with confusion. Uh, you're right, exactly. This is porphyria. And this is very high yield, guys. You know, porphyria is very high yield. I mean, this is a trick. It's not a high yield topic, by the way. But the trick about porphyria, whether due to drug or due to the clinical case, which is abdominal pain, confusion, maybe skin problems, photo, whatever, so you'll go with acute porphyria or porphyria cutanea tarda. I forget there are two. I think the acute one is without skin. There are two, guys. Sorry. Yeah, so the cutanea tarda is for the skin. So I will just put porphyria because I don't think if it will be this kind of questions, I don't think he will ask you to differentiate whether the acute or he will just ask you what is that, just porphyria. Then that's it. Anything about tremor essential that I forget? Topiramide is also a rule, although it's last choice. I remember it's maybe third or within the second, but usually topiramide is also a rule in essential tremor. I talked about essential in details because it's very common, and essential consider outpatient treatment, so it's very interesting and very common. So you get the features, which is basically you'll see at least one or two questions in your Q bank, and you get treatment also at least one or two. They really like tremor, so you get tremor for Parkinson, and you get tremor for essential. And the last tremor, last tremor, I think it's very easy. Where I talk about intentional tremor, which is the one with cerebellum. It's also tend to be slow, and he has to give you some features, which is nystagmus, diplopia, or whatever. Not diplopia, nystagmus, and this stuff about tremor. Alright, so let's move to the movement disorder. I'm still in movement, which is particularly Parkinson disease, which is the tremor part, right? So let's see. The first feature of Parkinson disease is what? The first presentation of Parkinson disease. How the patient present? You know, it's old age, so it's easy. How the patient present? With a